Hello, welcome. I'm Natalie Giacondo, President of MPN Advocacy and Education International. We provide educational programming, support, and advocacy for people with myelofibrosis, essential thrombocythemia, and polycythemia vera. Today is the first time we've ever hosted a webinar specifically for our community in India. We hope that this is something we can do again. And today we're joined by Dr. Bose, who will talk to you more about myeloproliferative neoplasms. If you have any questions during the presentation, please click the button at the bottom of your screen that says chat and write your questions into the chat. We'll have Dr. Bose address these questions after his presentation. So without further ado, let us please welcome Dr. Bose from MD Anderson here in the United States. Thank you so much for joining us, Dr. Bose.
It's a pleasure to be able to do this. I am actually currently in India. I'm visiting my parents. So I'm actually it's what is it? It's 7:30 p.m. right now, just like for the rest of our viewers. So Natalie, if you don't mind, if you would let me know how you'd like me to approach this. I mean, do I talk about MPNs in general, or do I wait for questions?
Sure. If you want to just talk a little bit about MPNs and sort of the diagnostic and treatment processes, and then we could just take some questions. A lot of the people that have contacted us to do this webinar were interested in getting some of their questions answered. So if you want, you can present. I'll take myself out, and then when you're finished, I'll help you to see the questions, and we can work it that way.
Sure, yeah, that works. I'll provide an overview of MPNs, and I'll get into, of course, diagnosis, little bit about prognosis, treatment. I'll try to give you an overview. I do a lot of drug development work myself, but I realize that some of that is not, a lot of that may not be applicable to the Indian context. So I'll probably not get into investigational treatments too much. And I'll probably talk about what we have today and what is relevant to the care of patients pretty much worldwide at this time. So, backing up and just sort of starting from the beginning, myeloproliferative neoplasms, and here we are talking about Philadelphia chromosome negative ones. Just to be clear, CML is the classic Philadelphia chromosome positive MPN, but at least in the US, when we use the term MPN, we are typically referring to, as Natalie said, the classic the classic Philadelphia chromosome negative MPNs, which is PV, the most common, ET, and MF. Now, again, they're actually fairly significantly different from each other. So, I'll try to point out those differences, but also the similarities. I mean, obviously, they are grouped together for a reason, right? So they certainly share some similarities, which are one, that they are all characterized by elevated blood counts, right? So in PV, it is all three, red, white platelets. In ET, it is platelets. And in MF, it can be whites and platelets, but usually the hemoglobin is low. That's a feature of MF and not of the other two. In PV, of course, it is high. And of course, MF has a bit more of color to it, a flavor to it than PV and ET. Frankly, MF is a later stage MPN. Now, let me be clear about that so that it doesn't confuse our audience. What I mean by that is, if you think of how the diseases arise in the bone marrow, PV and ET are considered manifestations of an earlier stage in the process of the disease's evolution, whereas MF is considered a later process. Now, some people can start with primary myelofibrosis and others can develop can develop secondary myelofibrosis after having PV or ET for a number of years. Now, again, so that was about the blood counts. Now, there are other similarities. So all three are characterized by some degree of splenomegaly, so enlarged spleen, and symptoms. Now, they're not going to be equally frequent in all three, but they're there in some fashion, to some degree. So what are the most common symptoms? So fatigue, inactivity, which goes along with fatigue, of course, trouble concentrating. Some people may call this brain fog or memory impairment, abdominal pain, early satiety, so the inability to eat a full meal because of the spleen, night sweats, fever, weight loss, itching, and bone pain. So these are the what are called the MPN 10. As you may have noticed, I mentioned 10 symptoms. So these are what we typically ask about. We try to capture, we try to follow them over time. So these are convenient. You can score them. You can, we give 10 points for each of these, and adds up to 100. You can follow that serially over time. I think it's ideal to do that, although it may be difficult to have the time for that during an office visit, but this is something that is highly recommended. So symptoms bind them sort of together: spleen enlargement of various degrees, maximum in MF, least in ET, somewhere in the middle in PV, obviously the blood counts like we talked about, and most importantly, they all arise due to overactivation of the JAK-STAT pathway. Now that's getting a little technical, apologize, but they are all driven by the same molecular abnormalities in genes called JAK2, JAK2, CALR, CALR, and MIPL, MPL. Now, obviously, it's out of the scope of this talk to go much into the biology, but they all end up activating what we call the JAK-STAT, signaling pathway in the cells, and this is what leads to this excess production of cells and eventual fibrosis in the bone marrow, which I alluded to. Some fibrosis can be present right at diagnosis, and definitely over time, people develop more and more fibrosis in the bone marrow. Now, another thing that patients often ask is, when did I develop this? Well, there is some very intriguing work from England which shows that the JAK2 mutation specifically, which is the most common mutation, it's 95% of PV patients, it's about 60% of MF, primary MF patients, and also 50 to 60% of ET patients, that this mutation can arise in childhood and even before birth. So it can arise in utero. So that's fascinating. So what happens is that the stem cell can acquire the mutation, but it's not until decades later that the patient actually develops signs of myeloproliferation. So the blood, most typically, it is picked up when blood counts are done, and you notice that one or more of the cell lines are elevated. That's typically how people are picked up, but the mutation can start way, way, way earlier. So just a common question that patients ask. Now, I was talking about fibrosis, and I do want to say one thing. I guess because the name is myelofibrosis, people naturally tend to fixate on the fibrosis, and they get very worried about the grade of fibrosis in the bone marrow. But I do want to point out that thus far, the evidence for the importance of the fibrosis grade is very minimal. In fact, there is evidence that the fibrosis grade does not correlate with any clinical endpoints. So I would discourage folks to focus too much on the grade of fibrosis and worry if they have a MF2 or MF3. it's not that important if the blood counts are good, as long as the bone marrow is doing what it is supposed to do, the fibrosis grade really doesn't matter much. So that was, another sort of an aside. Um, so hopefully we've covered some of the, unifying themes. Now, these are all cancers. Sometimes that may not be made clear to the patients, but they are all malignant. And actually, in the US, I'm not sure if this matters in an Indian context, but in the US, the recognition that these are cancers actually can help people get certain benefits and certain, privileges that come along with the cancer diagnosis. But again, that may not be as relevant here. And they are cancers because they are stem cell disorders. I mean, these mutations are occurring at the stem cell level, and they are leading to this excessive proliferation of cells, and ultimately, fibrosis, and unfortunately, transformation to AML, acute myeloid leukemia. So that is the most dreaded complication, and unfortunately a rare one. But when it happens, there is almost nothing that we can offer patients from a medical perspective, with only stem cell transplant being a potential modality that can lead to long-term survival. So I'm talking about, clearly, just to be clear, post-MPN AML, which is really, unfortunately, a very devastating complication. Whenever possible, you try to get the patient in remission, get the blasts down, and take them to transplant. Now, coming back to PV, ET, and MF, chronic phase PV, ET, and MF. So diagnosis, right? Diagnosis, well, it depends on the bone marrow. I mean, bone marrow is essential for the diagnosis of all three of them. Now, I know that oftentimes a bone marrow is not done. People make the diagnosis from the blood work. Now, I'm not saying that that is not possible. It is possible in the case of PV, for example. But I don't encourage it. I definitely encourage getting the bone marrow. The bone marrow can give you additional information that a blood cannot. For example, is there fibrosis already? Because if there is fibrosis already, when you diagnose somebody with PV, the chances are higher that they will develop post-PV MF. And then, one can also, there are these tricky cases where the bone marrow is the only way to know if it is PV or ET. It's not always clear from blood work. So, in the blood, you check blood counts, you check the mutations, you check the erythropoietin level. So again, I'm going to be cognizant of the time and scope of this discussion, but I won't get too much into those. But I do want to emphasize the need for a bone marrow. Even ET can be confused with what is called pre-fibrotic primary myelofibrosis. So you see a patient who has elevated platelets. If you don't do a marrow, you may tell them, hey, you've got ET, you have nothing to worry about, you're going to have a normal lifespan. But they may in fact have pre-fibrotic primary myelofibrosis. So I would really like to emphasize the importance of getting the bone marrow biopsy, because that is the only way you can distinguish between some of these entities. Now, again, if you have somebody with obviously very high hemoglobin, hematocrit, low erythropoietin level, JAK2 mutation in the blood, well, that's PV. But again, hopefully it was clear that the bone marrow can give us some additional information. Now, these days, everyone is doing a myeloid mutation panel. That can be done on the bone marrow, of course, and also on the blood. I do encourage that, although I will say that the treatment so far does not, at least today, the pharmacologic treatment does not depend on the mutation. So if resources are an issue, then that is certainly something that can be skipped, because the importance of the mutations is really for prognosis. So, and just to be very clear, I'm talking now about non-driver mutations. So I'm not talking about JAK2, CALR, and MIPL. Every patient needs to have that done. But I'm talking about these extended panels myeloid mutation panels or next generation sequencing panels that people are increasingly using. And I support that. But I want to point out that the utility is really in knowing what additional mutations may a patient have, which some of which are adverse and impact prognosis, and therefore may inform a decision for stem cell transplant. This applies to myelofibrosis. Sorry to have to keep jumping between the three diseases, but I don't think there's a good option otherwise, because they are, pretty related in many ways, which is why they're grouped together. So in terms of prognosis, generally we say that ET has a normal or near normal survival. This is why the distinction of ET from pre-fibrotic primary myelofibrosis is important, because pre-fibrotic primary myelofibrosis has a median survival of around 15 years, whereas ET is typically normal. Now, PV typically has a prognosis of about 18 to 19 years. Myelofibrosis, primary myelofibrosis, about 6.5 to 7 years, whereas if myelofibrosis develops after PV or ET, it is a bit better. So, for example, post-PV MF, median survival around 8 years, post-ET MF, median survival around 14.5 years. So the point of telling you this is just to give you a general idea of where they stand. These types of numbers are never useful for a particular patient. So please do not take these to apply to you. They are just general statements which tell us that ET is the best to have. Primary myelofibrosis is the worst. Post-PV, post-ET is better. And PV, of course, is somewhere in the middle between ET and MF, but closer to ET. So now, while speaking of prognosis, there are many models, numerous models. This is just to give you a general flavor. If we are talking PV-ET, then typically we are looking at the age, white blood cell count, prior history of thrombosis, this type of thing to try and get an idea of the survival. If it is MF, we are looking at a bit more things. We are looking at, of course, blood counts, chromosomes, other mutations besides the driver mutation, and many, there's a lot of intricacies. There are 8 to 10 different models just for MF. These are survival prediction models. Why are they important? Not to choose which drug. It does not help you with choosing the therapy, but it helps decide who to send to transplant. Again, back to PV and ET, remember, these are the more indolent ones with a normal to extended survival, let's at least put it that way. Remember, PV survival is not normal, but it is still pretty good. So there, we are not talking about transplant, because transplant is a hammer, as you can consider. It is not a gentle treatment by any means. Transplant has its own treatment-related mortality. So you don't want to do transplant in a disease where you're already going to live 20 years. So it's never done for PV and ET, to my knowledge. I once had a very young patient around 19, 20 years old who really insisted on getting a transplant, but he was turned down because the transplant physicians just won't do it. Because, again, the risk is not worth it in PV and ET. So how do we treat PV and ET? I think it's a good time to get into that, and maybe we can stop around kind of the halfway mark for this webinar. So in PV and ET, to date, for the most part, our goal has been reduction of blood clots, because we don't have treatments that can prevent myelofibrosis or prevent AML. Because if we did, everybody would want that. But that we don't really have. I'll come to what may be an exception, but right now, we still, in most of the world, I think we focus on reducing blood clots. And our audience would know that hydroxyurea has been a long time sort of standard for that purpose. Phlebotomy also in the case of PV, where your hematocrit must be kept under 45 at all times, no exceptions. So, so these are some goals, that are universally agreed upon, less than 45 hematocrit in PV. In ET, it is a bit hard to know what the goal is because the platelet count does not correlate at all with the risk of clotting. So we don't know what level to bring them down to. This is a very frustrating and difficult area because then you wonder, okay, why am I treating? I mean, there is data that giving hydroxyurea reduces the risk of clotting. And so we do give it, we do use it. But unfortunately, there is not a good platelet target. For example, these days, the thought is going towards less than 600 rather than less than 400 because the tight control may not be important. Now, again, I talked a little bit about prognosis and survival, right? But also there is risk stratification for clotting. So again, I won't go into too many details, but in PV and ET, where the main thing you're trying to prevent is blood clots, and remember, blood clots can be a heart attack, a stroke, a pulmonary embolism. It can be something bad. So in PV and ET, the main goal being reduction of blood clots, we have to risk stratify patients. So in PV, it is still pretty simple. If you're older than 60 or you've had a prior blood clot, you're considered high risk. And if you are younger than 60 and have never had a blood clot, that's low risk. In ET, it's a little bit more nuanced. I don't want to confuse you with too many terms, but there is very low and intermediate and high risk for clotting. It's based on age, prior clot, just like PV. But in the case of ET, the mutation also plays a part. Because remember, I don't think I said this earlier, but PV is almost 100% JAK2. So there's no heterogeneity. ET is only about 50 to 60% JAK2. So there's also CALR, there's also MIPL, there's also triple negative. So the clotting risk sort of varies according to the mutations. For example, is the lowest for CALR. So these things have to be considered, these nuances have to be considered, and every patient should know what risk of clotting they have. It's important to have an aspirin, baby aspirin. We call it baby aspirin in the US, but low dose aspirin, 75, I think, in India, 81 in the US. So important to take that every day for PV and ET unless there's a contraindication. Higher risk patients, generally hydroxyurea, and the goal again being to lower the risk of blood clots. Now, I mentioned that we don't have anything to reduce the risk of MF or AML. That may not be 100% true because now the field of PV at least is moving more and more towards interferon and ruxolitinib. There is data, again, because of time constraints, I won't get too much into it, but I'll just tell you that there is very intriguing data that interferon and ruxolitinib may actually be able to modify the underlying biology of the disease, which hydroxyurea cannot do. Hydroxyurea reduces the risk of clots, but these do that, and additionally, they may lower the JAK2 level and they may lower the risk of getting MF or AML. Unfortunately, it's not 100% clear. It's not something that is proven in large randomized trials. So but it is a direction in which the field is going. So let me conclude with MF treatment. So this was about PV and ET from a treatment angle. So MF, remember, I already said median survival 6.5 to 7 years. Again, please do not take any of you this information personally because every patient is different, and this is why there are the models to tell you where you fit or where you fall. But for MF, transplant is important because you're looking at unfortunately a not that great median survival. So transplant should always be considered in higher risk MF patients. But the treatment of MF today is still really revolves around JAK inhibitors. Now in India, you certainly have ruxolitinib. I don't know for sure if you have fedratinib and the newer ones, probably not the newest ones, pacritinib and momelotinib, but you definitely have ruxolitinib. This is a really fantastic drug. It has been a transformative drug for many patients around the world because it really shrinks the spleen very nicely and makes people feel a lot better because it suppresses inflammatory cytokines. It's a very potent anti-inflammatory drug. Because people feel better, they also live longer. This is also proven. So ruxolitinib has a survival benefit and definitely spleen and symptom benefits. It causes lowering of blood counts, at least towards the beginning. So you've got to try and manage that, add something for the anemia, for example, which always happens, or dose adjust the ruxolitinib. There are many nuances around this that we may or may not, have time for ruxolitinib management in everyday practice. I mean, but it's a drug that has tremendous benefits, but also has this issue of lowering the blood counts. And so the dosing can be a little bit nuanced, as well as people can add drugs to support the hemoglobin, presuming that you do not have the newer JAK inhibitors yet in India, the momelotinib, pacritinib, which have some other benefits in terms of anemia, platelets, etc. So ruxolitinib, I think, is the cornerstone. Remember, it does have that survival benefit. It is better if it is started earlier in the disease, but one should have some spleen or symptom issues. I'm not suggesting that it be used just with a diagnosis of MF. One does need to have some splenomegaly or symptoms, but there is data that if you start it early, the benefits are greater. And again, transplant always needs to be considered for higher risk patients, like I said, with MF. Ruxolitinib can often get people in better shape for transplant by shrinking that spleen so that, people are more likely to engraft and have a successful transplant. So I think with that, I'll stop this sort of impromptu overview and see what questions there might be.
Thank you so much, Dr. Bose. That was excellent. I think people got a good idea of sort of this overview that you talked about, and prognosis and treatment options and diagnosis, and that was just wonderful. So we do have a few questions. You may have covered some of these things as you were speaking, but maybe we could just go back and circle back to them.
Sure. So do you mean the Q&A chat in the Zoom?
Yes, I don't know if you could see it, but I'll go ahead and ask you the question just so everybody can hear.
Please, sure.
We may have at some point someone may type in a question in Hindi. I don't know if you're comfortable answering those questions, but we'll just take it as it comes.
Sure.
Okay, this is from a moderator of an MPN group. I have quite a few members from India, and they have trouble finding a hematologist knowledgeable about MPNs. Are there any specific doctors or hospitals that you could recommend or you feel comfortable recommending? Let's start with that one.
So, yeah, I've been asked this before. I'm actually not aware of someone that specifically focuses on MPNs. Okay. And that may just be hard in the landscape of practicing in India. But Vikram Matthews at CMC Vellore is a very highly thought of leukemia expert who certainly does MPN and is involved in some MPN initiatives. So that would be somebody that I can think of. Dr. M.B. Agarwal in Mumbai. I've actually done some webinars for him on MPN. Again, I'm not saying that either of them is MPN focused, but they may be good resources for MPNs.
Great, thank you. And perhaps we can get some links to the videos that you've done for them, and we can share them with our patients if that's possible.
Yeah, so the webinars I've done for Dr. Agarwal, just to be clear, are for a physician audience.
Oh, I see.
So they've been quite technical, but
Okay, well then maybe not, but thanks for sharing those names. A second question from the same participant says, my second question is regarding access to treatment. I have communicated with people who have family members with MF and are unable to access JAK inhibitors or SCT due to the high cost. Are there any programs to help them pay for these, or is MF just a death sentence here?
well, I mean, that's very sad to hear, but I mean, so this is again, you know, it's primarily ruxolitinib, as I understand, in the Indian context. And one issue perhaps that impairs my ability to give a good answer to this is that in the US, ruxolitinib is actually marketed by Incyte, whereas in the rest of the world, it is by Novartis.
Right.
So that is why I'm not able to speak specifically to any programs that Novartis may have in India. But of course, generally, pharmaceutical companies do have assistance programs. I know that's not a very helpful answer, but in general, in the US, we do find a lot of, you know, patient assistance programs that these companies have.
Thank you. You know, our advocacy team here can look into that and hopefully find some answers to what types of programs Novartis is offering in India and try to share that information. Thanks for asking to that participant. Okay, is primary MF hereditary, and can they be passed from one generation to another? Is this the case with JAK2 mutation?
So this is a great question. So, and it comes up a lot. So it's actually a very interesting answer because it's not very straightforward. Hopefully this will be clear, but in general, no. In general, a patient who has an MPN should not have to worry about passing it on to their kids, you know, as a general statement. However, MPNs do run in families. They can, I should say, they can run in families. So if you have a first degree relative with MPN, or even maybe a second degree relative with MPN, there is a chance that your family has a genetic predilection to acquiring the JAK2. So not JAK2 per se, but there may be a genetic, we call these haplotypes, but that's getting a bit technical, but there are certain genetic predispositions to acquire JAK2 that can run in families.
I see. Okay, great. Thank you. In India, doctors are not giving interferons, only hydroxyurea. Is there any drugs rather than hydroxyurea?
Yeah, so this is another great question. So I alluded to this a little bit, you know, the field of, I'm presuming the patient is meaning PV or ET. The field is definitely moving towards interferon, definitely. Now, I don't know if you have Besremi in India, BESREMI, which is a ROPEG interferon alpha 2B. We have that in the US, but also in Europe. In fact, before the US, 2019 European approval, 2021 US approval. But even if you don't have it, you should have Pegasus. Pegasus is pegylated interferon alpha 2A. Now, so again, Besremi is a ROPEG interferon alpha 2B. That's the newer one, the more expensive one. But there is Pegasus or pegylated interferon alpha 2A, which is made by Roche. Besremi is made by a company called Pharma Essentia from Taiwan. But going back to Pegasus, that has been around a long time, a very long time, and never actually approved for MPNs, unfortunately. So it can be a little hard to get in countries where, you know, it's insurance, you know, you got to get insurance clearance like in the US. But if someone's considering it out of pocket, it's probably much more affordable than Besremi or Ropeg. And again, it's made by Roche, so I would look into that.
Right, that's something else we'll look into for our the people watching today. So someone has asked, my sister has PMF grade 3 and taking Jakafi based on suggestion from hematologists. Suggest any MPN specialist, we spoke about that, whom we can take consultation in India face-to-face or anywhere nearby areas. So I think you addressed that, but if you have something more to say.
Yeah, unfortunately, not anything beyond what I already said. But again, in case you missed this part of my earlier of the earlier part of the webinar when I was sort of giving that overview, don't worry too much about the grade 3 fibrosis per se. The grade 3 fibrosis, yeah, it's a pathologic grading, but if the blood counts are good, then you really don't have much to worry about. Did I hear that right, Natalie? Was it grade 3 fibrosis?
Yeah. Grade 3.
Okay.
Yep.
Okay.
Yep.
Yeah, so that is the highest grade, and people get alarmed, but it's really about the bone marrow function and not about the grade.
Gotcha. And we get this question a lot about whether or not doctors in the US, like yourself, are able to consult with patients in other countries such as India, or able to consult with doctors, their physicians in that country. What do you have to say about that?
So not in an official capacity. So I cannot do, let's say, a televisit with a patient in India or anything like that. But we try our best to help out colleagues by email. If people email us, which they do, we always try to help in that fashion. And sometimes there can be some organized collaborations between a center of excellence in the US and say some sort of a partner or sister institution in another country, but those are specific relationships, between like A and B, but otherwise, generally, we do our best to be helpful through email or, but not in a formal setting.
So that same person asked, is it possible to share your information with the group so that they are able to pass that on to their physicians and possibly have a situation like you mentioned?
Well, I mean, yes, in principle, certainly, but I'm sure our audience understands that there is always a constraint of time, but I would certainly try. Yes.
All right, so thank you. What about anagrelide for ET JAK2 negative?
Yeah, so not a very good drug in my opinion. Not a fan of it. And just to be clear, JAK2 negative doesn't matter here. Okay, so it can be JAK2, CALR, MIPL, whatever. They are all being driven by the same JAK-STAT pathway. Now, anagrelide is a very non-specific drug that just lowers platelets. It is actually inferior to hydroxyurea. It was shown in a randomized trial. So I don't usually use anagrelide. In my view, I use either hydroxyurea or interferon as frontline treatments for patients who need cytoreductive therapy. Now, if somebody is intolerant or resistant, yeah, I may use anagrelide, but it's a very limited drug, and in terms of what it can do, it can just lower the platelets, and that's all. So and also it has some troublesome side effects. So I would not want to use it. In the US, we can often use ruxolitinib, even though it is not approved for ET, we can often get it. And it works, and it, obviously it has, being a JAK inhibitor, it has many more benefits over something like anagrelide.
Good to know. Okay. Will hydroxyurea cause itching near the uvula after taking? And sir, can you please say about hydroxyurea side effects and drug allergy symptoms?
So I don't know specifically of that particular issue. I've not heard that, but the common ones of hydroxyurea are, Well, first of all, hydroxyurea is generally well tolerated. It is, I don't want people to think that it commonly causes problems, but it can. So it can cause oral ulcers. So it can cause some discrete mouth ulcers or leg ulcers as well. It can cause fever, although I've never actually seen that, but it can cause fever. It can cause a little nausea. It can cause a little hair loss. Because remember, it is chemotherapy. It is, at the end of the day, it may be a pill, but it is chemotherapy. So it's not a targeted therapy like JAK inhibitors. It is plain old chemotherapy. So those are the main ones. So oral ulcers, leg ulcers, fever, nausea, hair loss.
Okay, great. Thank you. I'm 75, PV for 8 years, take HU, blood counts well controlled so far. Should I switch to interferon with the hope of preventing MF and increasing OS?
Yeah, great question. And see, this is the question everybody's asking. But I will say that it is more relevant, obviously, to people who are quite a bit younger. So, for them, just preventing blood clots is not the whole goal, right? So somebody in their 40s, it is more of a interferon discussion. So I'm not saying that at 75 you don't need it, but I'm just pointing out that PV in general has a good outlook. You're probably looking at a close to 20-year survival. I mean, again, one has to, and I said this before, that's purely a median, right? So every patient is different, and your personalized survival prediction depends on your age, white blood cell count, history of clots, mutations, things like that. So anyway, but my point being that generally it's a favorable, prognosis disease. And so at 75, I wouldn't feel compelled to change to interferon, because remember, interferon is not clearly proven to be disease modifying and improve survival. But I'm not discouraging it either. I mean, if you are able to get it, if you're able to get on it, sure, you could try it. But just remember that interferon is slower acting. So Hydrea acts quickly. So interferon may not control your blood counts and eliminate phlebotomies as quickly as Hydrea will. So just remembering that part. And again, overall, my answer would be, sure, you can try if it's available, but probably not imperative in your situation.
Got it. Great. Thank you. Any proof that interferons can reverse bone marrow fibrosis? Does it have to be given early?
Yes, so there is evidence that they can, but these are fairly small studies, but there is evidence that they can reverse bone marrow fibrosis, as someone asked. And yes, they need to be given early. But remember, in PV and ET, those are already early in the disease spectrum. So if you go in at when the patient has PV or ET, that's early enough. But if you're talking MF, then yes, interferon is not useful if you go in with advanced fibrosis. You need to go in early.
Okay, great. At what age can we expect myelofibrosis? And we, in the young age, having 25, we are having ET, but in cases saw MF at age 50 plus, can we expect myelofibrosis below 50?
Yes, you can. It is not common, but you can, of course. Yeah. I have patients with primary myelofibrosis in their 40s. I have several. But I'm not saying it's common, but of course you can. Yeah.
Okay. Is it more difficult to manage a patient with myelofibrosis that has anemia or a patient that has cytopenia?
I think they are meaning thrombocytopenia, I assume. Because, obviously anemia is also a cytopenia. So I would say that it is a little bit easier to manage anemia because there are more things we can do. You can use erythroid stimulating agents. You can use danazol. I don't know if you have luspatercept, but you can use luspatercept. So there are more things we can do for anemia. Now there is a new JAK inhibitor, momelotinib, approved in many countries, which which improves anemia. So there are more things we can do for anemia. There's less we can do for platelets. Harder to bring up really low platelets. In that context, I'll say that again, the newer JAK inhibitors, pacritinib and momelotinib, at least allow themselves to be used in people with low platelets, although they don't really bring them up very much. Low dose thalidomide, 50 milligrams a day, and danazol can increase platelets to some extent. But I will point out one thing. I'm not sure if this is the this is the perspective of the person asking the question, but for patients, I think anemia is much worse because a patient doesn't even feel the platelet count, right? So for the patient, the anemia is a much bigger problem. If they are needing transfusions, they are tired all the time. So from that perspective, it is a much bigger deal. But I think for the physician, it's a little easier to manage anemia today than very low platelets.
Perfect. Great answer. Thank you. For high-risk MF with low platelets and low HGB, which medication can be given alongside Jakafi for balancing the blood counts?
Yeah, I think I was just answering this. So this is the kind of what I was saying. If Jakafi is your only JAK inhibitor, then and you don't have the newer ones, then you can simply you can try adding danazol. You can try adding an ESA, erythroid stimulating agent. You can add even low dose thalidomide, 50 milligrams a day, not more than that. And we have a drug called luspatercept, which may not be there in the Indian market, but in many parts of the world, in Europe and the US, it is around for MDS. It's approved for MDS anemia, which also works very nicely for MF anemia. So those are some things that one can add.
Okay, great. I missed the first part of your presentation. What are worrisome signs of progression of PV to MF?
Lowering of the or I should say decreasing hemoglobin. So a patient with PV typically has high hemoglobin, right? And they are needing phlebotomies, or they are needing hydria, they are needing something. But if they stop needing that, if they stop needing phlebotomy, stop needing hydria or whatever they're taking, and the hematocrit is just staying under control on its own or even dropping, that is usually the most common clue that they are progressing towards MF. There are others, like the spleen is enlarging, white cells are going up. There are definitely other things. LDH is going up, or they are developing a lot more symptoms. But mainly, it's that hemoglobin dropping.
Okay. Okay. At what dose does hydroxyurea decrease spleen and blood counts? At what is maximum dose that you can take of hydroxyurea?
Well, I use 2 grams a day as the max. I don't use anymore. But if you ask the question, why not? Well, I mean, I'm not saying that there is a certain ceiling or cutoff, but the reason I use 2 grams is the European Leukemia Net, ELN, has defined hydroxyurea resistance or intolerance. So, and they say that if it is 2 grams, if you're at 2 grams and you're still needing more, well, then hydroxyurea is failing and you need to switch to something else, which is usually Jakafi in PV at least. Sorry, what was the first part of the question?
That's a good question. I believe the first part. Sorry.
Something about dosing.
At what time? Yeah. What's the highest dose, and also at what dose does it decrease spleen and blood counts?
Well, I mean, there is no real answer to the second part because it's variable for everybody. I mean, people could take even 500, which is one pill, every other day, and still that may be enough for some people. Others may need 2 grams a day. So there is not one answer on this for everyone.
Okay. Okay. Jakafi 25 milligrams 2 times a day for PMF being taken by 42-year-old patient. Spleen size is being decreased and blood counts are in control with without infusions. How to decide what is right the right time for BMT? Should we postpone it or take the risk? ASAP? This
Yeah,
is
this is
the
a
10 HLA match.
right, right, right. Yeah, yeah. And I was also reading it, Natalie, as you were
Oh,
reading
good.
it out. This is a great question. It's a big dilemma for people. This is a young patient who is feeling well, counts are good, things are going well on Jakafi. I always worry that any targeted therapy will stop working. So I always have that at the back of my mind. If the sister is a 10 out of 10 match, young patient 40 something, I would strongly recommend considering transplant. But of course, I don't know the specifics of the case. I mean, if this is a low risk patient, really no red flags with their mutations, chromosomes, blasts, etc., maybe you can wait. But at that young age with a matched sibling, I would lean towards transplant.
Thank you. Good to know. Do you like combination therapy for myelofibrosis? What combinations can lead to improving overall survival?
Yeah, so this is where we are now in the field. So this is where all the excitement is in combinations. We don't even have any approved in the US, so we are some time away from that. But yes, I mean, we are all looking for the ideal combination, which will be disease modifying, which will improve overall survival. Although overall survival can be a little difficult to show in a clinical trial where you take frontline patients, because it's just practically hard to do such a long trial. But you can show things like progression-free survival or event-free survival. So the most excitement now today is about a combination with pelabresib. Pelabresib is a BET inhibitor that belongs to a company called MorphoSys, which is being integrated within Novartis as we speak. So this is a highly watched drug. They've done a phase 3 trial. They're going to apply to the FDA. We'll see what happens. But in my view, if you ask which is today the most promising combo, it's probably that one. Although, the results were a little bit mixed, so people are kind of wondering what's going to happen. But yeah, today with what we know, I think that's a very promising combination.
Got it. And we're going to just take a couple more questions and then close things out for today. So we'll take these last questions and then let's see. Is hydroxyurea okay at the age of 25?
Not ideal. I would not want it if I were 25. I would want interferon.
Okay, good. And only JAK2, no other mutations. NGS report shows no other mutations. Oh, this is from the same person. So
That's
same.
good news. That's good news.
Okay, good. And last question. Once low level blasts start to show in peripheral blood, less than 5%, how long usually until they progress to 20%?
Yeah, so remember, the person hasn't told us if they have PVET or MF, but I mean, again, assuming they have MF, because that's where you typically see blasts, it can go on for a very long time. I mean, really, this is not enough information to try to answer that, because it depends on the biology of the disease. If they don't have any molecular high risk features or chromosomal high risk features, they could go on 20 years without having an AML transformation, but unfortunately, as I said earlier, AML transformation is the most, which is 20% blast. That's what the question is referring to, is the most dreaded complication. It's a very devastating complication when it happens. And generally, if it's at all helpful, the rate is about 20% at 10 years. So 10 years of having primary myelofibrosis, this is not PV or ET, need to be clear on that. If you have primary myelofibrosis, generally speaking, at 10 years, the risk is about 20%. But obviously, it's going to vary a lot based on the biology.
Okay, great. Thank you so much for your time today. You fit us in during your travel and your busy schedule, and we just can't tell you how appreciative we are. And we hope that we'll continue to see you in the future. And of course, we'll share with you and this group a video recording of this. We'll post this to YouTube and all of our social media channels. If anybody has any additional questions, they can contact us. The best way to find us is online at www.mpnadvocacy.com. You could sign up for our newsletter there, see our upcoming events. We so appreciate everybody in attendance today. We hope to do this again. And as you can see, you're getting thank yous and hearts from the people who joined us today. So thank you very much for your time. I hope everybody has a great rest of their evening.
Thank you for having me. Thank you everyone for listening. I hope it was helpful. It's a complex topic. It's hard to sometimes convey some of the technical facts to a more lay audience. But again, thank you for having me. Enjoyed it. Hopefully you all benefited from it.
Thank you so much. You did a wonderful job. Thanks again, and we'll see everybody soon.
Thank you.